Good morning, good evening, afternoon, everyone. Thank you so much for joining this webinar. I am Dr. Pratim Baiwa, and I'll be your host for today's session. Welcome to the second webinar in our series, Partnering for Health, Applying Private Sector Strategies to Public Health. Thank you again for joining us today. Today, we'll be focusing on integrating supply and demand creation interventions by harnessing private sector principles. Our objective is to explore how integrated health communication campaigns can deliver, supply, and drive demand for health services, drawing on the expertise and strategies from both public and private sectors. We have an exciting lineup of speakers today, including subject matter experts from Project Last Mile and our valued partners. Before we dive in, let me go over the format for today's webinar. We'll begin with a keynote presentation, followed by a panel discussion, and then we'll open the floor for a Q&A session. Throughout the webinar, we encourage you to participate actively through our interactive polls and discussions. Before we dive in, a few housekeeping notes. You can ask any question anytime using our chat or Q&A functions. We'll address these during the Q&A session towards the end. And don't forget to complete our post-webinar survey, which will pop up as you exit the webinar. Your feedback is invaluable to us. Now, let's get started with the poll. You'll see the poll on your screen now. And the question is, have you considered integrating supply and demand strategies to achieve a public health goal? Please choose the option that best describes your experience. The possible answers are A, yes, we regularly integrate both. B, yes, but we haven't started yet. C, no, but we are interested in learning more. D, no, we focus on either supply or demand. E, I'm not sure, looking forward to learning today. I'll give you a few moments to submit your answers whilst I reread them. A, yes, we regularly integrate both. B, yes, but we haven't started yet. C, no, but we're interested in learning more. D, no, we focus on either supply or demand. E, I'm not sure, looking forward to learning today. Okay, now we're going to read the results. Okay, we're just waiting for the results to come in. Just give us a second. Okay, we're still waiting for our results to come in, so just give us a few more seconds to get our results in. So it seems like today we have a little bit of, oh, there we go. Now we have the results on the screen. So 45% of you all said, yes, we regularly integrate both approaches. 0% said yes, but we haven't started. 9% said no, but we're interested in learning more. And 45% also said, I'm not sure, looking forward to learning today. Thank you so much for participating in the poll. Let's start with a quick overview of Project Last Mile. Project Last Mile is a unique public-private partnership involving PEPFAR, USAID, the Global Fund, the Bill and Melinda Gates Foundation, the Coca-Cola Company, and the Coca-Cola Foundation. We were established to leverage the supply chain and marketing expertise from the Coca-Cola ecosystem and apply these best practices to strengthen public health systems. Our focus is on using private sector strategies to enhance the availability, access, and uptake of health commodities and services. Over the past 14 years, working closely with ministries of health and our donor partners, Project Last Mile has implemented these capabilities in 17 countries across Africa and reaching over 43 million people today. Now, I'm excited to introduce our keynote speakers for today's session, Amanda Manchia and Jose Neves from Project Last Mile, who will provide a deep dive into integrating supply and demand creation interventions. I'm thrilled to introduce Amanda, who serves as the strategic marketing technical lead at Project Last Mile. Amanda brings with her an impressive 25 years of corporate experience. Having worked with some of the world's leading multinational companies, she spent the majority of her career at the Coca-Cola Company, but her expertise also extends to Unilever, Tiger Brands, Cadbury, and Schweppes. Since 2016, Amanda has been at the helm of Project Last Mile's strategic marketing projects, and we're really excited to have her today. Next, we have Jose Neves, who has also been a vital part of Project Last Mile since 2016. His work spans across Mozambique, Eswatini, Liberia, and the Democratic Republic of Congo. Jose's role in Project Last Mile builds on his 25 years of experience within the Coca-Cola system, where he's held executive roles in South Africa, Eswatini, and Mozambique. He's also a registered chartered accountant, and Jose has also contributed his expertise as a trustee on various boards and oversight committees across public, private, and non-profit sectors. Amanda and Jose, over to you.
Great, thank you so much, Pretty. So I'm going to just jump right in the interest of time. Let us just take a step back and just establish the foundation for where and how this project that we're going to share came about. So obviously, what is the need? So we're here to fulfill a need always, and essentially, it was something about revitalizing prevention. So obviously, care and treatment has done a great job in protecting people from losing their lives to HIV. But as we always say, prevention is better than cure. So continued and ongoing methods of prevention are still very important. And obviously, in this instance, we were looking at prevention in terms of condoms, because they obviously prevent many things, HIV, STIs, and unplanned pregnancy. So there was a need for an enhanced focus on prevention via condoms. From the donors' perspective, they thought that would be an interesting idea to bring across the idea of condoms in a refreshed and invigorated way, using the private sector model, not only to brand development, but also to route to market integration. And of course, the whole project only came about because of the support and sponsorship of the National AIDS program in Mozambique, and we have Ezekiel here representing them. Our role, of course, was to look at how do we approach this key aspect of HIV prevention in Mozambique, and obviously this was building on a previous history in the country that PLM has of over 5 years. So if we go to the next chart, we'll see that the condom usage in sub-Saharan Africa is low, and this is particularly low in Mozambique. Mozambique provides free of charge government condoms. They're not branded, but they're free and flavored and available. I just thought that maybe the Mozambicans lied less than other people about the use of condoms, but apparently they have validated some of the statistics on low usage. Nonetheless, they're not too dissimilar from other sub-Saharan African countries. And in sub-Saharan Africa, as of 2017 estimates, it was estimated that about men, on average, the need was 26 per man. And actually, the only 10 condoms per man were actually distributed. And when people were asked about their use of condoms, and these are Mozambique statistics on your right, they were not very high. Any of the claimed usage statistics, they were all below 50%, which is a really concerning trend. So two sides of the coin, as we know, supply and availability, and then, of course, demand creation, education, and motivation to act. So on the next chart, I think one of the things that we brought across with the private sector approach, particularly from Coca-Cola, is the fact that everybody drinks the same Coke, the same refreshing, sparkling liquid, but not everybody experiences it in the same way or the same bottle. And I think condoms, this is the kind of thinking that we applied to condoms. So we said there is work that is specifically done with condoms in the key populations, but as regards the general population, there should probably be a little bit more thinking in terms of where and how is the landscape or the location in which people are experiencing and then picking up condoms. So that was kind of like a guiding principle going into the project. On the next chart, you'll see that, as you're aware, and I'll explain a little bit more in a few charts to come, but essentially when we do our landscape analysis or our current reality, we found some very interesting things. So obviously from the earlier charts we had from the country itself, a lot of data and statistics that we use to set the data context, but then we did some formative research, and after all of the discussions and after everything had come down to what was the bottom line, we actually came to the point of saying, when you use a condom as a man, there's a cost-benefit equation. And as far as most men are concerned, the costs of using a condom far outweigh the benefits, even though those benefits are particularly significant. And so we have to make it easy for men to pick up condoms, or for people to pick up condoms for that matter. And we often quote our Eswatini colleague Cabo when she says we've got to take it to the people and we've got to make it fun. And so that's essentially what we had picked up from the cost benefit, was how do you make this cost benefit equation not so arduous? How do you kind of equal it a little bit? We also, as part of all the analytics, unpacked the availability, and we realized that what we would call an access point for where condoms were available, they were primarily available in facilities. Facilities, as we know, close at 3. But I think there were condoms that were being made available on National AIDS Day and so on, and by partners. But this was very opportunistic and very ad hoc. So there was no consistent supply. There was also a level to which we got great data, and then after that there wasn't. So we had to factor that in, and obviously no data at the kind of point of demand. And then when we did a large current reality analysis, we realized that if you look at private sector condoms and the way they are marketed, they talk about sex and fun and all that sort of thing, whereas the development, from a developmental perspective, the communication was actually just about education. So not about that fun. And all to say, after all that work and analysis, we developed a brand called Fajbem. Fajbem means you're doing well in Portuguese. And then obviously in Portuguese, it says use the free condom. And we applied this brand, Fajbem, and a very bright and impactful visual identity system, as you see there. Firstly, we had the visual identity and the brand on buses and on a very large wall murals and other forms of just general awareness, including radio. We had a radio novella. We were also on social media. We also then translated that visual identity look and feel through to where the condoms were now being made available in an enhanced fashion. And double clicking into that integrated approach, if you recall, I said earlier on, everybody drinks the same Coke, but they don't experience it. We realized that there were different levels of messaging as regards condoms. Obviously, you need education messaging, but you also need motivational messaging. And so we had a segmented messaging execution approach, which is different messages were targeted at different availability locations. And just to get to round out the strategic marketing component for now, on the next chart, you'll see the process that we follow. And regardless of what project we briefed on or what is the need we are wanting to address, or the requirement we're wanting to address, we follow this process. And I think that's what is very, very resonant of the private sector, is that private sectors drive a lot of consistent process. And that's how things happen well and improve year in and year out. And just some key high-level elements of our process is that I've mentioned already is what we call current reality, and that's learning everything we can about the landscape that we are operating in or need to go and operate in. We obviously then look for gaps, and where we need information, we inform those gaps with formative research. And that's what we did in this instance. And that's how I was discussing earlier the overall finding about cost benefit. We then worked with a local Mozambican agency, Dens Who Create, who did a great job. And they put together our communication and creative campaign. We then embarked on a great deal of stakeholder engagement. In fact, as part of that engagement process, we had come up with another brand, and as part of the stakeholder engagement process, then went with the second brand option based on the feedback of the stakeholders. And then a lot of obviously media planning, but together with the route to market team, a lot of integrated planning as regards availability and where we were going to place the various awareness mechanisms and how we were going to promote and drive demand for the condoms that were now increasingly available. As always, this was a pilot in one, but we made sure that we did a pre-survey and we made sure that we did a post-survey so that we could assess the impact of the brand and the campaign, but also that we could unpack shifts that happened in claim behavior. And then as a result of all that we learned in the test market, we have now put together a proposal on how we can scale the brand nationally and how we can have a more scaled national approach to route to market and enhanced availability. So let me stop there from the strategic marketing side and then hand over to Jose on the route to market side. Thank you.
Right. Thanks, Amanda. So I'll talk a little bit about route to market strategy. We started by analyzing the current condom distribution landscape to identify opportunities for increase in availability, efficiency, and accuracy. This analysis led us to develop a segmented channel strategy that included a variety of access points, such as barakas, taverns, grocery stores, spas, restaurants, health facilities, and even government offices. The goal was to understand the current landscape and develop a robust plan that could enhance distribution across the district of Buwan in Mozambique, where we piloted this. Buwan is about an hour's drive just outside Maputo. We can go to the next slide. Currently, condoms in Mozambique are primarily available at health facilities that close, by the way, at 3:30 in the afternoon, with only sporadic availability elsewhere. I also want to meet that guy that plans this that far ahead, just in Mozambique. This limited distribution model restricts access, particularly for those who might not visit health facilities regularly. And definitely, the product was not in the right place at the right time. Expanding access through non-traditional channels, such as taverns and spa shops, could help bridge this gap and make condoms more readily available to those who need them. Campaign and channel-specific messaging materials were placed at points of offtake. We had some edgy ones, and you can see it there, the edgy ones were placed only in toilets, for example, in bars and nightclubs. Our pilot operations were carefully planned. We can go to the next slide, thank you. Our pilot operations were carefully planned and implemented over 6 months in Buwan. We focused on two main routes, traditional public health services, route to market 1, which received approximately, in that specific area, around 39,000 condoms per month before the pilot, and non-traditional access points, which we called route to market 2, received from 18,000 to 36,000 units per month, but very variable. By ensuring the right quantities were supplied to the right places at the right time, these targeted, with the correct targeted messaging, we were able to improve the availability and accessibility of condoms for all. This approach also provided better data visibility over the course of the pilot. And by overlaying these access point locations with the population, with density data, we were able to highlight our coverage in B1, ensuring that we reached as many people as possible. The next slide, please. Thank you. Okay, in fact, I spoke to that one already, so we can go to the next one. Thank you. Okay, so by ensuring availability and accessibility and with better data visibility and control through managed and differentiated execution, the objectives were achieved in B1. Condoms were supplied to the right place at the right time with the targeted messaging. This was executed effectively, efficiently, and consistently through the use of third-party actors. So key lessons, as you can see, some of the KPIs on that screen, key lessons from the program, including the, no, go back to the previous one, please. Sorry, I think I might have confused the slide order. So key lessons from the program included the importance of well-defined contracts. No, go back. Yes, that one. Thank you. The key lessons from the program. So that includes, as I said, key metrics. And key lessons from the program included the importance of well-defined contracts, monitoring mechanisms, and the gradual scaling of the programs. Early development of electronic tools, diverse pickup points, and continuous private sector engagement were also critical for the success of the pilot, and they are reflected in those metrics that you can see on that screen. Thank you very much. So I'll hand back to Amanda now.
Oops. Thank you, Jose. So just to round out the presentation on the pilot in one that we did of the integrated model, what were the results? So I mentioned earlier that we had set up in advance a metrics evaluation and learning protocol for the pilot, and we did it in such a way as to be able to scale that nationally should the time come. Where the rubber hits the road, and because we now had enhanced data capture and metrics, which was incredibly helpful, based on the previous estimates, so the best estimates that people gave us on what was available before and what we could deduce at the levels of supply, there was a 243% increase in terms of the number of condoms that were distributed through the course of the pilot versus the average before. And I think a lot of this were related to the fact that the number of access points, so other than facilities, ad hoc, and a few other places, government offices and so on, the increase in the number of access points, so including taverns, which are called barakas, and other focus areas, this has resulted in, a 43% increase in the number of locations where condoms were available versus what was the situation before. From a campaign awareness perspective, even 6 months after the campaign was launched, which was a very short period of time, 82% of the Bwana residents were aware of the campaign, and we had a number of other metrics as well, and the brand and campaign were very, very well received. And then, of course, we also, as part of the surveys, measured, or they claimed, but measured shifts in awareness and attitude, and we had big shifts, 18% in knowledge increase, 29% belief in efficacy of the government condoms, and 32% increase in the indications of usage. So overall, we are we're very, very happy with the results, ecstatic in fact, and really look forward to getting as much scaling opportunities out of the model as is possible. Just to round out the presentation, on the next chart, we just thought that it might be interesting to put together that what were the learnings for us from this public-private partnership, given that we had really adopted an integrated approach. So this speaks to the whole approach. The first one is partnership building. So this is a team sport, and there is no way that this can be done if you just kind of like parachute in and do it. The requirement to align and get people in the ministry, people on the ground, in the provincial authorities, civil society, various other partners, And this, and also using a local agency, were all fundamental in terms of getting us to get the project across the line. And this, of course, will help if and when we manage to scale it. This leads to the next point, where that there is no way that we as Project Last Mile can know the local market as well as the people who are based there. And therefore, we have got to increasingly make sure, and a key component of success will be leveraging that local knowledge and those local partnerships to the maximum. On the third learning point that we really want to get across is that when we developed the pilot for Buan, we developed it for national scaling in mind. So we didn't just look at Buan and say, what is the best solution for Buan? We looked at Buan and said, how can we use Buan as a test pilot for a national model, so that we could take all those learnings and then not have to reinvent the wheel where we went somewhere else. We certainly need to make sure that this is not a PLM brand. This is a brand for the national AIDS response in Mozambique, and they need to be completely on board, and it needs to be owned by them over time, and we will be here on a decreasing basis, just providing support as required based on our various levels of expertise. And then finally, it's very important to be flexible and to bring a tonality to the project about learning. So pilots are very helpful because they are a kind of lower risk option to test ideas and practices that you can potentially scale nationally, or just scale however far you want to scale it. And so therefore, keeping in mind and the overarching goal of what you're trying to achieve, because you don't want to like also throw the baby out with the bathwater. So you keep yourself, you focused on the overall goals, but be prepared underneath that to pivot and kind of be flexible in making adjustments to the model in order to improve it once you've actually taken it off the PowerPoint chart and are starting to implement on the ground. So that's the kind of synopsis of the case study that we wanted to share with you on the integrated model. And I think I'm handing back to, I'm not sure, but I think Wendy will tell me. Thank you very much.
It's me. Thank you very much, Amanda.
Cool.
And thank you so much for this really insightful presentation. And I really love how you highlighted from some of the learnings, the importance of partnership, and also these partnerships being locally led, locally driven, and locally owned as well. And so building on that, we're now going to move on to our panel discussion. And I am really pleased to welcome our esteemed panelists today. Next, we have Ezidio Nantumbo, who has dedicated the last 10 years to working at Mozambique's National AIDS Council, where he focuses on the condom sector and currently serves as its coordinator. Ezidio is particularly passionate about creating demand for condom use. He believes that by combining efforts to increase demand with ensuring the availability of condoms, we can significantly reduce new infections, not just in Mozambique, but across Africa and globally. Joining the panel as well is James Flood from Frontline Research Group, who brings 14 years of experience in the fast-moving consumer goods sector across over 15 African countries, including work with the Coca-Cola Company. For the past 6 years, James has consulted with Project Last Mile in Mozambique, applying Coca-Cola's best practices to improve the availability of life-saving medicines. James has also enhanced the capacity of government supply chain teams in spatial analytics, route optimization, which boost visibility and help in decision-making in last-mile distribution. So we're going to dive right into our panel discussions, where I'm going to pose a few questions to our panelists just to give us a little bit more insight into the Mozambique condoms work. So I'm going to start with you, James. You were integrally involved in integrating these two work streams. Could you explain a little bit more about how the two were integrated?
Thank you, Pretty. I appreciate the opportunity and for the kind introduction. So, absolutely, we worked very closely. Amanda and the team was a key part of the success of the project on a number of levels. So, right from the I guess the scoping, the design, the implementation, and then also the tracking. It was an integrated approach from the very beginning.
Thank you so much, James. And I'm going to kick another question to Isidio. Isidio, from CNCS's perspective, how has integrating supply and demand helped to increase condom distribution, availability, and also usage, whilst driving positive shifts in awareness and attitudes?
Okay, thank you, Pretty. Let me first tell you that on our strategy, the demand creation and that availability are the two of the three pillars that are the most important. So the work we've been doing, we discovered that you can't do either demand creation or make condom available one without another one. They must be done at the same time. What we did on demand creation, first of all, we had to think out of the box, because we used to do messaging using that the traditional channels. But we thought, why should that has to work with the private sector, in this case with the Peliam? They have another way of thinking. It's a private thing. Maybe they bring some clues or some light to our way of working. It's important to say that the work we did on demand creation was to look, as Amanda said, to each age group, to each kind of population, and creating some kind of communication for each of these kind of segments. And at the same time, we look at the condom availability, and we saw that, okay, using our traditional ways of making the condom available, we're not reaching the results that we want. That's why when we look at this partnership with the private sector, using their way of work, we saw that, yes, we have some kind of results better than the one we used to have.
Thank you very much, Isidio. That was very insightful, and I really love how you've talked about not being able to have one without the other. So when you're creating demand for a certain product, you also have to make sure that the product is readily available for the people to be able to access it conveniently, and also to have messaging that resonates with them. And so I guess it goes back to Carbo's statement about taking it to the people and making it fun. So you take the product to the people, but you also make it fun by making messaging that resonates with them and that clearly they can identify with. I'm going to come back to you, Isidio, again with the next question. What were some of the key factors that contributed to the success of the condoms pilot in Boan, and also how can these be replicated in other regions? How are you seeing this happening?
Okay. First of all, we had to start the market to understand where we was really failing. And from there, we defined actions to be taking account, as I said, that the segmentation of messages for each group, for each kind of age group with each kind of population. One other innovation that we had is which is providing good results is to use the mass media to disseminate those messages. We saw that using that mass media, you have results in a very huge population in a short time, different of using the traditional channels. At the same time, we wanted to ensure that the condoms are available at the last mile, and we had to understand the customer's perceptions on that kind of condom availability, and it helped us to on the communities, on the level of community, we found places where we can store the condom. We can call it the hubs or storing points, where the organization for the community can go and they have the condoms to do their work during their work sessions. At the same time, we guarantee the transportation, the condom for the upper levels to that level until the hubs. So we can take the condom must be available there. But at the same time, we help another organizations that don't have the capacities to go to that hubs and get the condoms. And we help them transporting that condom until the organizations so they can have the condom available to do their work. So I can talk about these 4 points, but there's a lot of findings that we can bring here. To disseminate to other regions, yes, we had that one experience. What we are doing now, as the country is huge, is taking some of the knowledge that we had in Buan and start to apply where possible, naturally, start to apply to see how can we leverage that activities for the organization on the level community so we can have the condom available at the last mile. Thank you.
Thank you very much, Isidio. And I really like how there's a continued thread of partnership that continues to come into this discussion as we talk about how, it was also about integrating other partners who also do the work with condoms distribution, but might not necessarily have the technical capability or even the distribution capabilities to be able to bring the condoms to their communities. And also, I really loved how you've spoken about thinking about non-traditional ways of giving populations access to condoms. So usually you find that condoms are mostly, put in toilets. They are mostly put in like very hidden places, but now with this strategy, there was thinking around putting them in barracas, putting them in at like bus stops so that someone can just grab it whilst they're heading home. And so really thinking about when you think about this integrated strategy, it's very interesting to note that there was a lot of non-traditional thinking that came into it, and also really making the campaign fun and so that it resonates with the rest of the population. I think that was a pretty interesting aspect to this work. So for my next question, I'm going to come back to you, James. With condoms being primarily available at health facilities, how can we expand access through non-traditional and decentralized channels? What have we learned from the increase in access points in Buan?
Interesting. I mean, there's certainly a key theme that's coming up quite consistently as I'd listened to all the other panelists discussing, and that's really having a consumer-centric mindset. But, keeping the question in mind, expanding to non-traditional outlets, I think it's very important to keep the end in mind. So, and that is the desired outcome of making sure the right products are available in the right quantities, at the right places, at the right time, the right, with the right positioning and targeted messaging. To do this effectively, it's very important to understand, what is required to meet those consumer needs. Isidio touched on that a little early on as well. So what are those products? What are those quantities? What is the messaging? What is the placement that is required to meet those consumer needs? So again, very much a consumer-centric approach. I think other key aspects to this is having a data-driven and insights-driven or an evidence-based approach. This is key, absolutely key. So if you're looking at expanding once again, I think there are a couple of key steps that I would recommend. Again, following this consumer-centric mindset. Again, understanding those consumer and patient needs, but more importantly, understanding where and when those are typically likely to take place. Then once you understand that, it becomes easier to design or at least conduct a strategic segmentation exercise. In other words, grouping these different outlets or access points based on where and when these consumer behaviors are likely to take place, and typically how these outlets, how they operate. Once you've had that in place, once you understand that you've defined the strategic channels, you're in a far better position to design a fit-for-purpose distribution or service model. And once you have in place, it's going to improve your chances of improving availability, accessibility, and doing so in an effective and efficient way. So I think, again, key parts of that, it needs to be evidence-based or insights-driven. And secondly, it's very much an integrated approach between your demand creation and supply chain or route to market teams. Thank you.
Thank you very much, James. And, I cannot emphasize enough, like how, the importance of data-driven insights and getting to know your customer or getting to know the person you would love to provide the service to. And so, it becomes very intrinsic that when you are doing these integrated approaches to ensuring availability of products in the right quantities, right, at the right place, and also even with the right quality, you need to understand the end user or the customer, the patient. And so, I'm going to also kick another question to you on data collection. How can we improve data collection and monitoring to better understand distribution gaps and opportunities for targeted interventions, such as the condoms work?
Sure, interesting one. And, again, keep that consumer-centric hat on. It's very important. That needs to drive all your decision-making. That needs to be critical when the design phase, the implementation, and then also the measurement and refinement of the model that you eventually put in place. But, thinking back to the success we had in Bhutan, there were a couple of tools, approaches, and methodologies that came to mind from a research and data collection perspective. Both Jose and Amanda touched on it in our integrated approach between demand creation and route to market teams. We did a thorough landscape assessment using mobile data collection tools in the target market, which was Bhutan, where we worked with key stakeholders like Ezedio and the different representatives from the provincial and district divisions to physically visit all of the different active access points that were distributing condoms. One, to geocode them, and two, to collect a lot of key information to get a sense of how many there are, what type of access points there are, how do they typically operate, what are their service needs, who's currently servicing them, what sort of volumes do they distribute, and a range of other key data points like that. Then once all that data collection is done, it's very important to map and visualize that in a range of different, and certainly in spatial analytical tools. So you map out your access points database, get a sense of where they are, what sort of coverage they have in proximity to population hotspots. Where are your different implementing partners active in terms of their operations, and immediately you'll start to see where the potential gaps in supply are and where the opportunities are, or the low-hanging fruit, as we like to call it. Building that all together, and then also validating or correlating that data and insights with key informant interviews. It really helps paint a well-rounded picture as to where the needs are and what the opportunities are. Then I think another tool that worked particularly well is once we'd used all these data and insights in this integrated approach, we designed a solution, we implemented it. We implemented a number of delivery tracking tools to monitor distribution and track offtake at the different access points where condoms are distributed to. We also were able to monitor actual versus planned distribution with the service providers that we brought in to execute this distribution model that we designed specifically for this market or this environment. So those are a couple of tools that work particularly well in Boan and just gave ourselves and a lot of the key stakeholders end-to-end visibility in terms of what the opportunities were and what needed to be done to be able to distribute on the levels that were required and meet demand. Thank you, Pretty.
Thank you, James. That was a really comprehensive answer. And, as we continue to just dive deeper into some of the, nitty-gritties of this project and also kind of focusing on the partnership, which really in this case, was something that CNCS has earned and has continued to drive. I want to kick some questions back to Amanda and Jose. In terms of continuous private sector engagement, Jose, this one is for you. So continuous private sector engagement has been identified as a cornerstone for success throughout this discussion, right? What strategies have been most effective in maintaining this engagement? And also, how can other public-private partnerships ensure ongoing collaboration and support with their Ministry of Health partners?
So the important thing to Ministries of Health is sustainability and capability building. So we need to ensure the transfer of knowledge, and that is why, at least in Mozambique, there is, whilst there may be some initial resistance, there is the private sector knowledge and transfer of capability is very welcome, but it needs to be performance managed. It needs to be cost competitive, and otherwise, especially with the use of third parties, there is a thinking that it is too high cost for governments to be involved in, and they lose control. However, in competitive environments, and if there's proper selection process, proper contracting, and proper performance management and compensation is tied in to delivery and performance, then over the long term, it can be shown that the use of private sector is lower cost and it delivers the results that's needed. So not only the Ministries of Health, but the donors as well. There's a huge focus now on knowledge transfer, capability building, and sustainability. And the idea is that not only in this condoms project, but also all the other work that we do in Mozambique, is that we are not here forever or for the long term. That when we leave, the knowledge and the skills remains with the partners and the people involved in government, in the supply chain of medicines. In the case of condoms, it's not just, as Izidu said, it's not just delivery or availability or distribution, because without the creation of demand, that won't work. So yes, knowledge transfer and sustainability are the key elements to make it sustainable.
Thank you so much, Jose. Knowledge transfer is a very important aspect to maintaining sustainability, and also ensuring that the partners are involved in each and every step of the process, and they actually own that process. And so thank you very much for those insights. I'm going to move on to Amanda with a last question on integrating public health campaigns. How can public health campaigns leverage private sector principles to drive behavior change and improve health outcomes, is specifically regarding condom use?
I mean, I think even more generally, there tends to be, I think, 4 things that, in my experience, the private sector does well from a strategic marketing perspective that perhaps doesn't translate as well in the health sector. The first one we spoke about already is just targeting, like know exactly who you're talking to, and just assuming that just because you want a lot of people to wear a condom, that you necessarily have to have it show up or have its messaging be the same for everyone. So, you know, not taking that broad brushstroke approach, but rather trying to tightly target and segment. I made reference of the fact earlier on as well around process. So having consistent processes around managing brands or developing brands, and then consistently communicating with the consumers or the potential patients, people, general population, whoever it may be, managing that methodically and from a process perspective is increasingly very important. And then I think just speaks to the integrated approach a lot more. You know, creating demand in a vacuum is, I mean, it's a waste of resources, right? So don't create demand if you aren't sure that you can fulfill it. And that's why having integrated approaches to demand and supply are critical to success, and were critical to the success of this project. The last point I think is the private sector tends to adopt not tell people what to do, but they sell ideas. And so, for example, we always use this example: Nike doesn't say buy running shoes. So we shouldn't say wear a condom. We should find another way, more entertaining way, a different way to tell people or to sell to people in order that they do what's good for them, for sure, but in a way that is motivating for them, and the benefit for them is clear, or at least it's fun and engaging. So that's what I think are the key principles that the private sector brings.
Thank you so much, Amanda, for such an insightful answer. And I really, really love the approach of the condoms campaign, Pashbam. It's really fun, you know, with all of it brings all of the really catchy colors, yellows, the reds, and also, you know, that actually is not really, we're really talking about a subject of condoms, which is related to HIV, STIs, and, you know, a high mortality rate on the continent. So it's a scary subject, but then this campaign actually made it really fun. And so I really do see some of that private sector thinking coming through to this strategy. I just remembered about the Coca-Cola campaign, which was like open up happiness, you know, and really, you know, that is catchy and that is also fun, but it's, you know, like when you're trying to encourage good health seeking behaviors, I think not fear mongering to the public is always a good starting point. So now we are running out of time. I would like to now move on to our Q&A session. But before I do that, I would really love to extend a PLM heartfelt thank you to our panelists, and also really extending a big thank you to Isidio for making time. We know that your work is, you have a very busy schedule. And so thank you so much for joining us today. And also James, and also Amanda and Jose, thank you so much for these valuable insights. So now we're going to take some questions from the audience before we round up. If anyone still has questions or comments, please also still pop them into the Q&A function as we're going. But I'm going to start with one question that's come on, and we've got 2 now. Some have been answered in the chat already. So anonymous attendee is asking, did you, I'm going to kick this question to Amanda. Did you find that the distribution and marketing teams were all on board? I'd imagine that there must have been some resistance to doing something differently. How did you handle that and get all the different stakeholders on board?
I think across the PLM team and with the National AIDS Program, we had quite a bit of alignment up front. But if I had to do it again, I would say that one of the key learnings for me would have been to start that process of alignment with the local teams much earlier and in much more depth. So we had a very short funding cycle. I think it was 18 months, and obviously a lot of expectation on delivery of actual results and campaigns and route to market strategies, as well as implementing the pilot and testing it all in 18 months. And I think given our private sector background, we just like charged ahead and forged ahead just to make sure that we could make those deadlines of having a 6-month, developing everything, having a 6-month pilot and being able to measure it. That I think the one thing that fell by the wayside was insufficient stakeholder engagement. So I think that for me is a key learning, because I think it's never sufficient, right? You can never get enough people on board. You can never spend enough time making sure that everybody's comfortable and aligned. And I think that for me is critical to us going forward, because it also forms part of the capability piece. You know, people need time to and exposure to be able to understand a way of working that is different, quite different in the private sector to how it is in the public sector. And in the public sector, I mean, we're not going and doing the public sector role. We're just expecting the public sector to do the private sector role, and it is alien for some people. And I think we need to make sure that we are much more. We spend a lot more time on this aspect.
Yeah, I just want to add to what Amanda said in terms of communication and stakeholder engagement and management. So whilst we involved in Mozambique in a couple of different projects, and condoms was one of them, with condoms we did provide comprehensive quarterly reports where we used it as also a base for documenting all the work that was done. However, what was missing in the condoms project, I think to Amanda's point, and that we successfully have in our other projects in Mozambique, is a steering committee meeting, a quarterly steering committee meeting. Everyone is so busy, and just having another report arrive in the emails is not as effective as having a monthly meet, not monthly, but with key stakeholders, including donors and the Ministry of Health, having a quarterly meeting with them, where you go through the report in more detail. Thank you.
Thank you so much, Amanda and Joseph. That was a really comprehensive answer to this question, I believe. And with that question, I am going to be closing the Q&A session. Unfortunately, we've run out of time. So we've almost reached the end of the webinar, and so apologies for not being able to have time to address all of your questions, but remember, there are more resources on our website. I want to quickly revisit the poll that we shared at the beginning of the webinar. How likely are you to apply integrated supply and demand strategies in your public health work after today's webinar? I'll give you a few moments to submit your answers whilst I read out the choices. So we've got choice A, which is very likely, I feel confident and ready to take action. Choice B, somewhat likely, I need more information or resources. Option C is unsure, still evaluating how it fits into our strategy. D, not likely, it doesn't align with our projects. E, not likely, it doesn't align with our priorities. Okay, so we are going to see the results. I'll give you a few moments to submit these. All right, so now the poll results have just come in. So the question was, how likely are you to apply integrated supply and demand strategies in your public health work after today's webinar? 80% of you have said that very likely, I feel confident and ready to take action. 10% are still unsure, while still evaluating how it fits into your strategy. And 10% said not likely, it doesn't really align with our priorities. Thank you so much to all of our speakers and participants for a really highly engaging and informative session. For more resources, please visit the Project Last Mile website, and we would also appreciate your feedback through the post-webinar survey that's going to pop up on your screen as you exit this webinar. We look forward to seeing you at our next webinar. Thank you all and have a great day. Goodbye.
Thank you.